I'd like to invite Jacque Caglia and her panel to join us on the stage. Jacque brings 20 plus years in public health and global development to her role as head of Merck for Mothers within the company's social impact and sustainability team. Today, she's moderating an exciting conversation on how communities are developing postpartum care and how payers and philanthropic partners can bring these solutions to scale.
Grab a microphone and get started while we rearrange the stage.
Here. I'm gonna give you. Here.
Okay, sorry. Okay. We do claim the prize for having the largest panel of the conference, so we will go ahead and take that. And we are going to do our very best to manage the time. We have a lot of really important information to share, so thank you for the opportunity to be here today to have a conversation about what we need to do collectively to advance postpartum care. The postpartum period is full of joy. It's full of discomfort, questions, sleepless nights, healing bodies, and a lot of firsts. It is a time when mothers really need comprehensive support with ease, and that support should be addressing their physical, emotional, and mental well-being. It's also a period where, in my opinion, and if you look to the data, where we have the greatest opportunity for improvement and urgency for changes, as our current default system of care across the US during the postnatal period is inadequate. And it's inadequate for people's experience, and it's also inadequate for addressing the challenges and complications that can arrive during that critical period. So as was shared, my name is Jacque Caglia, and I am the head of Merck's Global Maternal Health Initiative, which is part of our company's Office of Social Impact and Sustainability. I have the privilege of moderating today's conversation, where we are going to hear from a diverse group of experts. Again, largest panel, give it up. These colleagues here represent a village of clinical, community, public health, policy, payer, and research perspectives. They are all leading efforts to improve postpartum care and ensure that all mothers receive the support that they need. I'm not going to introduce them. They're going to introduce themselves. So let's get into it. I'm going to turn first to Vanessa Landrum, who's seated next to me. She is here from Birth Detroit in Michigan. Vanessa, please briefly introduce yourself and describe how Birth Detroit delivers postpartum care, centering your 4 core values.
All right. My name is Vanessa Landrum. As she said before, hello, everyone. I am representing Birth Detroit. Birth Detroit is the first and only birth center in Detroit, Michigan. We are Black woman owned and operated. So all of the clinicians that you see at Birth Detroit are Black. So how do we encompass our 4 core values at Birth Detroit, which is safety, love, trust, and justice? At Birth Detroit, we believe that postpartum care is not just a single checkup. Postpartum care is ongoing. And so at Birth Detroit, we don't just check in on our clients one time. When they leave our birth center, we check in on them 24 hours postpartum. We check on them 5 to 7 days postpartum, 2 weeks, and 4 to 6 weeks. They also have access to midwifery care 24/7, even after they have given birth. We have 2 avenues of care at Birth Detroit, which I would love to highlight. One is the avenue of birth center birth, where you come with us and you birth in the birth center. And the other is the Easy Access Clinic. That is where you can get care regardless of ability to pay. So clients can come to us with little insurance, insurance with high copays, no insurance at all, and they will still get prenatal and postpartum care. The postpartum care on the easy access side, you deliver at a hospital or at home, and we still come to your home. So we mobilize to your home. And the way that this is so important, especially in addressing maternal mental health, is that being able to look at your clients and see how they are postpartum. Not just a phone call, not just, a text message. We are coming to your home. We're mobilizing to your home. We're seeing that we're walking into your home and we're like, hey, you got a sink full of dishes and you got laundry everywhere. And we're not just saying, hi, great to see you. Great to see the baby. We are helping you clean your home. Did you take a shower today? Did you eat today? How can we help you today? These are all things that we're doing at Birth Detroit to make sure that we encompass our 4 core values.
Thank you, Vanessa. Thank you, Vanessa. Keep losing my mic. Safety, love, trust, and justice.
Yes.
I think those are 4 values that each and every one of us in this room and online can get behind. It's what our mamas, our sisters deserve. So we're going to stay in Michigan, and Melissa Scodellaro is here from the Fourth Try Sanctuary. Would love if you could introduce yourself, and then please describe for us the new pathways that you and your team are crafting for support around the postpartum period.
Yeah, thank you for having me. Like she said, my name is Melissa, and I'm the president and the co-founder of Fourth Try Sanctuary. We are a new concept that opened last February. We are the first non-medical community care coordination facility. We're dedicated to supporting moms in their postpartum journey. We've recently been featured at NPR as America's Next Postpartum Care Model, PBS, CBS Nightly News, in America, American Institute of Architects, for how design can change postpartum outcomes. All those links are in the document page if you'd like to view those. A little background before embarking on this journey. I'm a hairstylist for 20 years. I own a hair salon for 10. And the common theme that I got behind the chair was mothers were seeking reassurance and support. And I was lucky enough during my early postpartum phase to have 5 moms of all different ages and backgrounds in my chair every day. So if I had an issue, I asked them, my baby's not sleeping. What do I do? The perspective was the key to my mental health. The perspective that every mom did it differently and their babies were okay. And that tomorrow is a chance to try again. So that is where the Fourth Try Sanctuary was born out of, the motivation behind my clients' testimonials. We are an in-person facility where moms come as they are. They come with messy buns, milk on their shirts, and we take care of them. We're a 6,300 square foot, all one floor facility. We have nap rooms for the moms. We have nursery care. We have a fireplace lounge. We have activity room. We have a cafe and grocery store that just recently launched on DoorDash, so we can deliver to the hospital and give moms some really good postpartum meals. Our amenities, I also include baby bathing stations and other areas where moms can practice being moms with doulas. We are primarily staffed by doulas. And our model is kind of based off of an all-inclusive resort where moms don't sign up for, we have daily activities that are approachable and help combat stigma. So most of our activities are done by doulas. Those activities were created by postpartum experts so that doulas could responsibly deliver this information. Because postpartum experts, as most of you are, realize that you are limited in your resources and you need support. So a lot of the questions I've heard here from the mental health experts is, what do we do after we diagnose? Well, you send them to us. If you can only see a patient one time a week, which is extremely fortunate for that patient, most of our mental health experts are not taking insurance right now, unfortunately. What do they do the rest of the time? They come and they hang out with us. We've been open a year and we just got our metrics back. The average mom spends 4 hours a day on site with us. Some of our unlimited guests, which is like an unlimited monthly membership, are spending 100 hours a month on site with us. These moms are not diagnosed with postpartum depression, although our team is trained in early detection, but also where our model is prevention through community and education. So because these moms are supported, they have that. Question is, I'm sure, how do we pay for this? We currently accept FSA, HSA. Our average cost is $34 an hour, so it's not extremely expensive, although that is expensive for people. And we do have a foundation that launched last March called the Fourth Try Foundation, which we have raised money, and we teamed up with Birth Detroit to give scholarships to some of their guests in other local communities. So we just applied for a grant through Henry Ford to hopefully increase our foundation access.
That's awesome, Melissa. Congrats. Thanks so much, Melissa. Dare I say, great hair and a great idea. I would like to hang out there. Really incredible work that you're doing. Okay, we're going to go down the line but hop a bit, and I'm going to come next to Katrina Moline, who is here from Hand to Hold, and would love for you to introduce yourself and tell us a little bit more about the special postpartum support that you and your team extend to families who have a NICU stay as part of their journey.
Sure, I'd be happy to.
It'll come.
Okay, there it is. Good afternoon, everyone. I'm honored to be here as part of this important conversation on advancing postpartum care. My name is Katrina Moline, as Jackie said. I serve as the executive director for Hand to Hold. We are a national nonprofit organization that is dedicated to providing early intervention, emotional and mental health care support for families who have experienced a NICU or a neonatal intensive care unit journey. That includes loss in that journey. And as Jackie said earlier, the postpartum period is supposed to be a time of immense joy. That's what we expect. But for parents who have medically fragile infants, nothing is as we expect. Moms are often separated from their infants for hours and sometimes even for days. When my son Bryce was born 4 months early back in 2009, I had to wait more than 2 weeks before I could hold him for the first time. He spent 5 months in the NICU. We had to basically disconnect our services from home and move to the hospital. That NICU became our way of life, and there's no way to prepare a parent for that. The anxiety that developed after his traumatic birth followed us home and was magnified by the isolation of being home with a baby who was tethered to an oxygen tube, needed a feeding tube to feed and survive, and needed continuous specialized care. I was in survival mode. It felt incredibly selfish to think about my own mental health. And as much as the people in my life were there to support me, they just didn't understand. And so what we do that's different at Hand to Hold is we provide somebody who gets it. We are centered on peer support as a model. And what that means is that we have certified mental health peer specialists. They are certified, they're trained, they're supervised by a certified supervisor, and then they have that lived NICU experience as well. So they're able to walk alongside these mothers and really understand where they're coming from and help them to not feel so alone. And that's really at the heart of what we do.
Thanks, Katrina. Really appreciate that work and the special care and attention that families who are experiencing that need. And I really just love the peer support model because sometimes it can feel so isolating going through the challenges of those kinds of experiences, and to know that you're able to lean on someone who's walked that road before, even if the contours are a little bit different, can be really helpful. So thank you. All right, now we're going to come back in the line to Fernanda Ruiz, who is here from Mary Center, which is based here in Washington, D.C. And Fernanda, would you please introduce yourself and tell us a little bit about how Mary Center is providing integrated care, and particularly through your home visiting program. And I remember as we were preparing, you also had some really interesting insights related to how you and your team are braiding together sources of funding to cover these services.
Thank you. Hi, everyone. My name is Fernanda Ruiz, and I am the home visiting director here at Mary Center, which is a federal qualified health center based here in the district and Maryland. We have a few sites in Maryland as well. Just to give you some context, Mary Center was developed about 35 years ago, actually based on the need that we were seeing in the community. At that time, there was a lot of women coming from Central America to DC who were in need of prenatal care. Many of them were fleeing violence in their home country because there was a lot of civil unrest at that time. And so a lot of women were coming here, and our founder, Maria Gomez, who is a nurse by trade, she identified this need that women were coming in need of prenatal care, and there was no one available to provide services in their language, and that were culturally appropriate. So she started a very small clinic at a basement providing prenatal care with a small grant, and that's how we were founded. as she started providing services, she noticed that sometimes women wouldn't show up for care. And so she started wondering, like, what's happening? We already have the clinic. It's in Spanish. What's happening? And so she started like asking questions, going into their homes, knocking on doors. And that's when we come into social drivers of health, right? It's great to have access to care, but if you don't have a roof over your head, you're not going to show up to care. If you're going through domestic violence, prenatal care is not going to be your priority. If you're struggling with depression or you're feeling isolated because you're new to this country, it's also going to get in the way of you being able to access care. So with that in mind is that she created what we have now as our social change model, in which is the way that we integrate services and we deliver care here in the DMV area. So we have three main components, which are health, social services, and education. Within health, we provide the whole preventive care from lifespan, from prenatal care up until senior care with a few specialties. And the whole idea is that we're going to have a family-centered approach in which we want to make sure that the whole family is seen at the same time by the same group of doctors. So instead of having a pediatric side, adult medicine, OBGYN, we have teams that have a pediatrician, OBGYN provider, a midwife, a adult provider, a social services person, behavioral health. And so again, the whole idea is that your health is going to be integrated. We're going to be sharing information. And so if a mom comes into the clinic and for a pediatric appointment and the pediatrician has a concern, she can bring it up or they can bring it up to the other providers. And so we can have a team approach towards this family. And so within that, so that would be the medical component. Within social services, we have regular case management. We have a very robust behavioral health department. We have a team program. We have WIC. We have navigation for public benefits, and we have a home visiting department, which is the one that I lead. And with education, we have we partner with a public charter school called Brilla, who provides education in a two-generation approach. So parents come to school while the children are also in school at the same time. So the whole idea is that we don't only want families to be healthy, but also for them to thrive. And so that's kind of like the way that we integrate. And within our home visiting department, we are currently implementing 5 different models of home visiting services, also understanding that nothing is like a cookie cutter approach. And we want parents to be able to identify which program would be the best fitting for them, whether they want someone to be at their home every week and providing like that close connection, or maybe they want something less intensive, maybe once a month, or, like there's different approaches that we can go. And the way that we've been able to fund it is we have a variety between private grants, we have grants from local government, federal government, and we are right now we're also generating a little bit of revenue within Maryland because of legislation that passed. We were, I guess, at this point, very close to pass legislation here in the district that we championed to be able to bring Medicaid reimbursement for home visiting services. However, with the whole context that we have right now and the district being very impacted, they're looking at making cuts. So it's not looking great, but we're going to continue with the fight.
Thanks for that, Fernanda. I so appreciate the way that you've described the integration really around the whole family and the opportunity that we have, especially in the postpartum period, to be thinking comprehensively about needs for mom, but for everyone around her as well. So thank you. Elly, Miles, let's come to you next, and we're going to put on our research hats. We know we have some data nerds in the room from our earlier conversation. So you and your colleagues at the Urban Institute have been studying the state of the field related to maternal mental health and the impact of home visiting programs like the ones that Fernanda leads. So what insights would you like to share related to what you found so far?
Thank you, Jackie. And like she said, my name is Elly Miles. I'm a developmental psychologist, a senior research associate at the Urban Institute, and a lead writer for the National Home Visiting Resource Center. The National Home Visiting Resource Center is a collaboration of Urban Institute and James Bell Associates, and we produce comprehensive information on the home visiting field. And one of the main things we do is produce a yearbook annually that kind of highlights the state of the field, draws attention to reach and access, of home visiting. And so what I want to draw attention to is that kind of narrowing in on home visiting for a few minutes is that home visiting is really, we think, a very promising pathway to increasing reach around the country, finding and working with women in their homes that are experiencing disadvantage, experiencing high levels of stress, often young mothers who may be missed in more traditional healthcare settings. And so there's already an infrastructure that really supports that. So home visiting is present in all 50 states and territories. And according to our most recent data, we know that more than 300,000 families are receiving home visiting services every year. So in terms of thinking about increasing capacity, for screening and identifying and supporting mothers, this is a really great way to do that work. But we know that there's a few challenges in the home visiting world that need to be addressed in order to move that work forward. One issue is that there's a very well-documented apprehension amongst home visitors broadly to address some of the more sensitive topics that we've talked about today and yesterday. Things like substance use, intimate partner violence, and mental health. While we know that those things are being encountered, that the families they're working with go through them, many home visitors don't have a background or specialized training in mental health that they bring to the field and often report feeling somewhat unprepared to tackle those issues. A related issue is that we don't have mandated screening outside of depression for maternal mental health. So there are national benchmarks for depression screening, which is fantastic. It's a great advancement and milestone in the home visiting field. But other broadband symptoms like maternal stress, maternal anxiety are often not even being asked about. And as Dr. Wisner pointed out yesterday, we know that comorbidity is a significant issue, and those mental health needs are tied to very similar child outcomes as maternal depression, and so missing them is consequential. And so thinking about some of those issues and how to start moving forward the conversation, we produced a report that sought to characterize the different ways that home visiting is currently being leveraged to address maternal mental health in the field. We wanted to kind of find and raise up those examples to encourage policymakers and program leaders to think about how they could kind of integrate more of that mental health focus. So we found kind of four, I'd say, primary ways, different ways that home visiting is being implemented with positive outcomes on maternal mental health. One way to bring attention to, and I think some people don't even know that this is a form of home visiting, but there are home visiting teams that integrate clinicians within the model of home visiting. They have licensed clinicians in interdisciplinary teams that are going into homes and providing services, parent-infant psychotherapy, for example, at the kitchen table. And those sorts of models are really responding to what we know is a high trauma background and often mental health burden, and finding ways to really meet that need with the highest level of training. We also see that many home visiting programs successfully partner with community-based mental health providers to kind of integrate alongside their teams and provide kind of streamlined access to services for families. Or maybe they contract with a mental health provider to provide infant and early childhood mental health consultation to their teams. And so those are ways in which you can get that highest level of care kind of integrated into the field. The other two approaches are more psychoeducational in nature. So some home visiting evidence-based models that don't really have a mental health component have effectively had a modular add-on of sorts to their programs. We've seen that with Nurse Family Partnership, for example, where they include some psychoeducational content, train the workforce, and have a kind of effectively integrated some of that focus to directly discuss these issues with mothers and parents. And then lastly, some home visiting models are more skill building and oriented in the way that they try to approach recognizing and managing mental health symptoms. Of course, this is all in addition to linking mothers with higher levels of care when it's needed. And some of these programs are rooted in infant mental health principles, even as they're being delivered by peer support workers, and really try to use structured, kind of sequenced approaches to develop a mother's reflective capacity. Reflective capacity is something that's really key for their own mental health and their ability to support the mental health of their children. So just wanted to kind of highlight those four areas to point out that there isn't really one way. There's a variety of ways that programs are doing this well.
Thanks, Elly. And we've uploaded copies of the reports, links to the reports in the app. So please, I encourage everybody to read them in full. I think the insights that you and your colleagues have gathered can really help us with optimizing different models of home visiting for the postpartum period. So thank you for that. All right, we're doing great on time, but we're going to come to our last speaker. We're going to turn now to you, Salma, Mohamed here from Mass Health. We're delighted to have you back on the stage. So we've heard a little bit through the panel so far about integrated postpartum care, about home visits, and about novel pathways that are really designed around what women, what families need. And we know you've been thinking about this deeply with your team at Mass Health. And so we'd love to hear what the latest is related to what you're supporting through Mass Health and how you're thinking about reimbursement for these types of programs in Massachusetts.
Awesome. Thank you for that question, Jackie. And hello again, everyone. My name is Salma Mohamed. As a reminder, I work at Mass Health, which is Massachusetts Combined Medicaid and Children's Health Insurance Program. And first, I just want to get into the lay of the land and let you know the kinds of things that Mass Health covers and the work that we're doing in Massachusetts. So as of April 2022, Mass Health became a 12-month postpartum expansion state. And thank you. Very exciting. And as part of this work, we allow all folks who are pregnant or postpartum to have coverage up to 12 months, inclusive of all pregnancy outcomes and regardless of immigration status, which of course is becoming increasingly important with the climate we're in currently. And so the ways that members can access continuous eligibility are through a variety of pathways. But one thing we really stress as an agency is self-reporting so that Mass Health is aware that a member is pregnant so that the benefit can extend through the postpartum period. We do have lots of pathways that support this in a more automated way, but self-reporting is definitely the most guaranteed way to make sure our members have that full coverage. And also to alleviate the burdens around, fears of, interacting with the state agency for a variety of reasons, whether that's related to immigration status or because so much of the benefit is attached to head of household. It also bypasses alerting the head of household that there is a pregnant or perinatal member in the family. And so, getting into a little bit of our covered services, we do offer comprehensive benefits for prenatal and postpartum care, including sexual and reproductive health, family planning services, and very excited to announce as of early this year, we did issue a standing order for birth control and prenatal vitamins. So for all of our postpartum and pregnant members, we do cover the O pill and other over-the-counter products for birth control purposes. And we also have the prenatal vitamins available for our members free of cost as well. And we do also offer coverage for remote blood pressure monitoring programs. I think it's really important to think about how mental health is definitely a major driver and complication in the postpartum period, but also want to be very inclusive and considerate of the various disparities that are encountered by members who are of different races. So Black women are increasingly more likely to have cardiovascular and physical health conditions. And so we want to make sure that we are responsive to the needs of all of our diverse members, of course. And so really exciting work happening at Mass Health. And we also have, there's so much to remember, so I'm trying to keep track of it all, but we have one of the most comprehensive transportation benefits in the state as well, where we give our members access to transportation services to meet their appointments. And this is, of course, increasingly important for our members who may have an infant who's in NICU. And so that is available to our members as well. Some really exciting news. As of August of 2024, our governor signed a bill into law entitled informally the Maternal Health Law that covers a wide variety of different services for perinatal folks in the state of Massachusetts, and included in that are mandates for Mass Health to cover home visiting programs, such as the ones that Elly and Fernanda were speaking to a little bit earlier, and also pay parity for certified nurse midwives and physicians to be paid at the same rates, where previously they were paid at 85% of the rates of physicians, which is really exciting. Also increased extended coverage to adoptive parents for the doula program, which I spoke to a little bit earlier, and lots of other exciting points around perinatal mental health as well. And so to get a little deeper into relating to some of the programs that folks up here have been discussing, definitely the first way to make these programs more sustainable and accessible to our member population is Mass Health covering them and creating reimbursement models that make these programs sustainable and accessible to our members. And so we are very much at the starting point of making things like this happen for our members. And home visiting policy is currently in development, so not much to share yet, but we are working closely with the Department of Public Health, who are standing up that model and own a lot of the home visiting programs in the state. And so we're really excited to continue doing that work with the Department of Public Health and figure out the best ways to make this model more sustainable. I think what's really exciting is that there are more opportunities for our members to get access to these critical supports in a community-based setting. It's definitely going to alleviate a lot of the social determinant of health challenges that make clinical support less accessible. And so I'm really excited to see what comes of that, and very hopeful to see some of the things that Elly shared also benefit our members directly as well. And for pay parity, that officially went to effect in January of 2025. And we've been hearing really incredible feedback from our provider community. We recently learned that one health center was able to actually hire 6 certified nurse midwives as a result of the implementation of this policy. And so really excited to see increased access to midwifery services for our members. We do know this is an evidence-based model and has some of the best maternal health outcomes. And so hoping that more of our members can have access to birth centers such as Birth Detroit, and access to providers as passionate and dedicated to this work as Vanessa is. And so I'm really looking forward to seeing the fruits of the policy development work that we're doing come to life. And yeah, there's just so much happening, and it's really all very exciting. And I feel very hopeful and energized to be in this space and amongst all of you, and really looking forward to hopefully have new exciting things to share next time we connect.
Thank you so much, Salma. You said you're at the starting point in thinking about sustainability, but I think that you and your team are off to a running start with what you've been able to get past. So congratulations, and keep at it, and keep sharing all that good news with us. All right, so our audience today here in the room and online are change makers in maternal health care and maternal mental health. And as the Policy Center refers to all of us, we're the 4 Ps: payers, partners, providers, and policymakers. So a question to the panel. I'd love for each of you, when you feel ready to chime in, to share what your ask is to one of the 4 Ps related to the support that you and the people you serve through your work need. You want to start? Yes, go for it.
Mine is to the payers. Our model is new, and over the last year, we've worked with the hospital at Henry Ford and their scientists to collect data from the moms. We send out surveys periodically throughout. Some of our guests are with us for a month, some 3 months, some for the whole year, about their outcomes and how we changed their lives, and we changed the support, how we changed their family's life, because we know if the mother's held and the mother's supportive, that has a huge impact on the child's mental health and the whole family's health. So our ask is to payers to recognize what we're doing. We'd love to get it covered by insurance. We are staffed by doulas. That was on purpose to hopefully get covered by Medicaid. So we're working on that. Unfortunately, we're on a startup budget, so that's some of those things are a little bit hard, but the foundation is helping to push some of those initiatives through.
I want to piggyback off that.
Another ask for the payers?
I haven't asked for all four, actually. And I also want to say that there is also an infographic that I would have hoped would have been up about postpartum care at Birth Detroit, but you can find it on the app as well. But to the payers, just like Melissa said, we need sustainable funding models that reimburse midwifery-led, community-led prenatal birth and postpartum care and mental health support. To the partners, we need your voices amplified during this urgency of maternal mental health and community-centered care. To our providers, I am a midwife by trade and a psychiatric mental health nurse practitioner student. So to my providers, we need deeper collaboration to decrease the stigmas and increase support surrounding community birth and culturally responsible postpartum transitions. And then to our policymakers, we need policies that recognize and fund midwifery care as a proven solution for maternal health. So my question to all of them is, what can you do in your role to move this work forward for us?
Thanks, Vanessa. I heard those asks loud and clear to all four Ps. Thank you. Anybody else want to chime in?
Sure, I'm happy to. So I think thinking specifically about providers and policymakers, just want to emphasize that there's multiple ways to increase a focus on supporting maternal mental health within existing programs. No need to reinvent the wheel. There's like a huge amount of diversity in the home visiting field, 27 evidence-based models, many more emerging models. There's ways to kind of enhance that focus on mental health within the existing models that exist. And there's a role to really look at the community you're in, look at the cultural preferences of the community, the resources, the assets, make decisions based on that. So, for example, if there's no pipeline for a mental health workforce in your community, maybe you are looking at more of the modular add-ons, more of the psychoeducational approaches. And also just want to mention that even without an explicit mental health focused model with a clinician embedded, just the presence of a supportive, strengths-based, attuned, reflective, trauma-informed home visitor is in itself a really powerful social support that plays a role in reducing mental health symptoms.
Thanks, Elly. Katrina, did you want to chime in with your ask? Go ahead.
I think the reality is that postpartum care can't be one size fits all. We have to integrate mental health support into standard maternal care, ensuring that all parents, regardless of their baby's birth circumstances, have access to sustained, high-quality support, whether it's through Medicaid reimbursement, hospital partnerships, or employer-based benefits. We need to advocate for policies and funding that prioritize postpartum mental health as essential, not optional. As we look towards solutions, I encourage each of you to think about the role that you can play, whether as policymakers, providers, payers, or community partners. What small steps can you take to move the postpartum mental health forward? Because when we invest in supporting new parents, we aren't just improving outcomes for moms and dads, we're shaping a healthier future for entire families. At Hand to Hold, we believe that care for the parent is care for the baby.
Thanks for that, Katrina. I think essential, not optional. That's your mic drop moment right there. Fernanda, Salma, anything you want to? Go ahead, please.
Thank you. I think my recommendation would be that it has to be in partnership, right? We need all four Ps to be working in partnership. We need like seed funding. We need the payers to also like recognize the services that are being provided and bring value base as well. We need the policymakers to be involved in this process and hearing also from the providers and the participants, the people who are actually receiving the services, to make the recommendations. And when we work in partnership, I think is when we can like make the most impact. And I think like at the beginning of the session, like Jacque, you were saying, like it's a village, right? And I think it's so true. We need a village to be able to like make impact and move the needle. And that's where I think we all come in with different lenses, different expertise, different life experiences. And yes, that would be.
Thanks, Fernanda. As one of the P's on the panel, do you want to chime in on what you need from the others?
Yeah, definitely. I think my question to all four Ps would be, how do state Medicaid agencies do a better role of being partners in this work? And how can we do a better job of hearing and responding to the needs that we're hearing from providers, from community partners, from even patients? I know that's not one of the Ps, but like folks who are benefiting from these programs, or maybe not benefiting because they're not accessing. And the other question I have explicitly for the Ps, the payers specifically, is how are you reaching to members, and how are you ensuring that there is actual utilization of the great work that you're doing? I think we're in a similar position as California, where we have a lot of the right tools in our toolkit, and implementation is really the biggest battle we have. And so want to make sure that our members are aware of the benefits and are actually accessing them. Otherwise, what are they there for, So
Thank you. Appreciate that. It reminded me of something we talked about yesterday about how coverage does not equal access. And you've done an incredible job related to what is able to be covered in the postpartum period. And now the real work is there within the partnerships on ensuring that that coverage translates into access and getting people the care that they need with ease. So we're almost out of time, but I'm going to try to do one more rapid fire question if everybody's game for that. So considering the various models that we've talked about, I'm going to ask everybody just sort of quick fire, 30-second response on your final thoughts on what you want to share about what is needed to advance postpartum care.
What is needed to advance postpartum care? We are needed to advance postpartum care. The community, everybody in this room, payers, providers, like you said, patients, everybody is needed to advance postpartum care. We need people to tell more stories. We need moms to tell more stories about how they survived, so that we can show everyone that this is not something that can be looked over anymore. We need to start making changes. So we need to, as a community, gather together and be that village for our birthing persons.
Thanks, Vanessa.
Mine would be eliminating the isolation during the postpartum period. We truly believe that community is the key to mental health. And not only do our doulas watch over the moms on site, but the moms end up helping each other and caring for each other after a while. And that spreads outside of our doors. So that would be isolation is the key. Curing isolation is the key to mental health.
I would say that we also want to highlight self-determination, allow families to make decisions for themselves, make recommendations, but also decide what is the treatment that they want to receive, or like what is the best pathway for them. I think when we are involved in our own care, that's when we're more engaged and we like get the most benefit out of it.
I think I want to highlight that peer support is a powerful model that can help address some of the gaps that we have all recognized in these last 2 days exist within providing mental health support to new parents. So just understanding and recognizing the value of peer support to help close those gaps. A lot of what we're hearing today is that moms need other moms, right? Nowhere is that more true than within the NICU.
The thing that I would emphasize is the importance of pouring into the frontline staff that are doing this work. And I think that really is something that crosses across all of our programs. You need to have the capacity being developed within you all the time in order to develop capacity in others and enhance their reflective capacity and work with them, provide those supports. It's actually a concept in infant mental health known as the parallel process, which is the idea that change in relationship-based work is happening on multiple levels all the time. So if you've got a really fantastic reflective supervisor that's supporting you with processing your experiences in the field, you're enhancing your capacity, that's going to have a spillover effect on the way that you engage with mothers as a home visitor. And as their capacity grows, then they're going to better recognize mental health needs in themselves and support the mental health of their infants and young children. So you've got to be pouring into the front line in order to do this work well.
Yeah, I'd love to echo everything everyone said on here. They're really incredible points, and just continue to emphasize breaking down silos and working in collaboration with all the folks who are invited to the table or should be at the table, and making sure we are keeping in mind that at the root of all of this work is our care for actual human beings and their lives. And so bringing that humanity back, even if we represent a system or something that seems more abstract and ominous, at the end of the day, we're all humans working in service of humans. And so keeping that central to the work is key.
That's right. And at the root, it's love, right? At the root, it really is love. So I'm so sorry. That's all that we have time for today. But I really want to thank our esteemed panelists for sharing their insights, their experiences, and for all the work that you do day in and day out. And while we do face a lot of challenges, especially with the shifting sands in the current environment, there are innovative models and innovative practices that can make a real difference in the lives of our patients, in the lives of the caregivers as well. So I think we can all agree it is time for comprehensive postpartum care to be fully covered and for it to be paid at acceptable reimbursement rates. So as we move forward, I encourage all of you to think about what you can do based on the discussions that we had today, and consider how to contribute to this vital work to advance postpartum care. And I think we're going to go to a short break. So thank you all. Thank you.